Right, it's right at the top of the hour. Hello and welcome to the ASLM special COVID-19 session number 3, an initiative of the ASLM, Africa CDC, FIND, ICVIA, and the Korea World Bank Partnership Facility. My name is Anafi Mataka from ASLM, where I serve as the project lead for the Accelerating Diagnostic Project, as well as project manager for the Laboratory Systems Community of Practice. A few logistics for today's session. This will be a 1-hour-long session, as usual, made up of a presentation, followed by a question and answer segment. Kindly remember to mute yourself when you are not speaking. Enter your questions or comments in the chat box as the session proceeds. As we start, a few remarks. COVID-19, as we all know, is an uncharted territory, the likes of which us, the present generation, have all never seen before. And we can only learn as we go. And that is the subject of our topic today, experience. As the saying goes, it is the best teacher. Today we are privileged to have our colleagues from the Republic of Korea giving us an explanation of how they contained COVID-19. Their topic is the current COVID-19 situation and response in the Republic of Korea, and what are the lessons we can learn on the African continent. Many of you are familiar with the Korean story who always remember patient number 31. Patient number 31, what was known as the super spreader. This is someone who is spreading infection to a larger number of people. And similarly, as you are realizing, I think we could be having these patient number 31s in our midst. Colleagues, I do not want to preempt the presentation. So let me introduce to you our speaker for the day, Dr. Lee Seon Erica. Dr. Lee holds a PhD in public health, law, and bioethics from Yonsei University, Seoul, South Korea. From 1999, Dr. Lee rose through the ranks in the Korean government to her current position, where she is serving as the director in the Division of Risk Assessment and International Cooperation in the Centers for Disease Control and Prevention, which is in the Ministry of Health and Welfare, also in Korea. Dr. Lee, the rapidity in which COVID-19 took hold of South Korea initially surprised the authorities. But we learned that well-established strategies were soon put in place. Please tell us how you went about it. Over to you, Dr. Lee. You can share your screen and we begin.
Thank you very much for a nice introduction. Greetings everyone. It's really my honor to share our knowledge and experience on responding to COVID-19 in Korea. Actually, we will, I think I will just go through our presentation file. Yes, this is our first page, and then the next page. Before I start to explain my situation.
Dr. Lee, I think you need to put it in presentation mode.
Okay,
yes.
Sorry.
Great. Thank you.
Okay, so I will start again. Before I start to explain our situation and response measures to COVID-19, I'd like to briefly go over our preparedness efforts after MERS outbreak in 2015 and before COVID-19 outbreak this year. Based on the lessons learned from MERS, Korean government reformed the public health emergency preparedness and response system since 2016. KCDC has gone through this reform in its organizational structure as well as the system. We have established a 24-hour and 7 days emergency operations center cooperation, Also, we increased the number of EIS officers and trained rapid response team, including field training as field officers. Then the infrastructure for public health emergencies have been expanded by increasing the number of isolation rooms and also negative pressure isolation rooms. In addition, we also strengthened the risk communication and risk assessment division. Actually, my division was established after the MERS outbreak. So this is kind of new division at KCDC. Next. I will just go over briefly about our KCDC Emergency Operations Center. This is the pictures of EOC, which was established since 2016 after MERS outbreak. First, we used the temporary EOC while constructing the new building that was completed in January 2018. After finishing the interior construction and the IT system installation, we officially opened this new EOC in March 2019. Next one. This is the working zone of a new EOC. When the EOC is activated, all the relevant officers from various divisions move to this working zone, and we work together in the same place with much easier communication and cooperation for collective response. This working zone includes the main room with about 80 working seats, and also training room, decision room, and operation room. Actually, our EOC watch officers are working 24 hours and 7 days for monitoring and surveillance in this the operation room. This picture is taken when we had a training session last year. Our EOC is a highly restricted area, so this was the only time we opened to the media. Currently, we are all gathered here, even now, and this place is the second floor of this EOC building, and work every day together. Next one. Now, let's move on to the COVID-19 outbreak. This slide shows the timeline, how the situation has gone, and how our government has responded to COVID-19. We issued alert level 1 after the cluster of cases of pneumonia of unknown origin in Wuhan, China, was first reported to WHO. We began to prepare for possible importation of COVID-19. The alert level increased to level 2 when the first case was confirmed in Korea, and then to level 3 after more imported cases were confirmed. Actually, at this time, the secondary transmission were reported after then. Finally, we raised to level 4, which is the highest level in response to the big clusters, Shincheonji and Daenam Hospital. This level 4, at this level, the whole government approach is taken. So we have this emergency headquarters under the right under the Prime Minister. So Prime Minister is organizing and holding the whole government and the local governments the committee meetings every morning, and then even now we are at the level 4, so we are actually working together and responding together as the whole government approach. Then this graph shows the total number of confirmed cases and the cases in each day since the first case was confirmed. As of April 6th, the first case was confirmed. There has been 10,284 in total. The peak of transmission so far was on February 29th, with a record of 909 confirmed cases in a single day. After them, though, newly added cases have slowly decreased. Since March 12th, the number of daily confirmed cases have been around 100. And then as of April 6th, actually till today, we are just currently under 50 cases. So we are now in quite under control, but we are still just trying to minimize all these the confirmed cases. This graph shows the weekly trend of imported cases. As you can see, the imported cases have rapidly increased since week 11, and the most cases are from Europe and Americas. In order to prevent further importation, we have strengthened even more at the point of entry. I will explain the details of special entry procedure when we conduct in a later slide. Next couple of slides are the basic epidemiological information of the confirmed cases. This slide indicates the distribution of cases by region and clusters. The graph on the left shows that Daegu and Gyeongbu provinces, where Shincheonji cluster was found, have the highest number of cases. Other regions, such as Seoul and Gyeonggi, and Busan and Gyeongnam, are also experiencing small clusters, bringing the current number of cases to around 500 and 100 respectively in the regions. The number of cases found in airport screening is 310 as of April 6th, and it seems to increase fast. We are keen to strengthen our screening system at the point of entry and actively monitor all the incoming travelers. The pie chart on the right is the proportion of clusters in Korea. Shincheonji is the biggest cluster as indicated in blue. Orange represents other clusters. In this slide, the one on the left is the age distribution of confirmed cases. The distinctive feature is that we have the largest number of confirmed cases in the age group of 20s. The reason we have more patients in age group 20 to 29 is because the big cluster religious group is mainly their religious activities. They are mainly targeting young people in 20s for their missionary works. On the right, you can see the number of fatal cases and the fatality rate of each age group. The highest fatality rate is 19.8% in age group 80 and above, and the overall case fatality rate is 1.81%. The next slide summarizes the response measures, especially after we found out local transmission, including Shincheonji cluster. Right after we recognized the case number 31, which was confirmed on February 18th, was related to Shincheonji religious group, we started to identify and test for all members of Shincheonji Daegu group. As cases increase and evolve to the big cluster, our government escalated the national alert level to 4 and designated Daegu and Cheongdo as a special management region on February 9th. When we had a peak on our epic curve, we started the social distancing campaign as well. Currently, we are conducting an enhanced social distancing campaign until April 19th. And the school opening has postponed. Also, while responding to this big cluster, we have taken various measures, including the update of case definition, designation of national safe hospitals, establishment of living and treatment supporting centers, deployment of public health doctors, and so on. As the number of imported cases increased again, we expanded the social entry procedure, including testing and screening for homecomers and travelers. Now I will explain on our lab capacity. Actually, after 2015 MERS outbreak, KCDC learned that the establishment of national laboratory system is very much required for public health emergency response. We are operating a tiered laboratory network from the national to the local level that is evenly distributed throughout the country. We also established a specimen transport arrangement with a 24 hours operation for confirmatory testing even before COVID-19. CDC can test 80 nationally notifiable infectious diseases. It's about 120 pathogens, and also developed laboratory test methods to identify unknown and emerging infectious diseases. This was done actually while we are responding to this COVID-19 at very early stage, very early January. Finally, we have established the emergency use authorization system. We call this EUA system, which permits temporary use of unapproved in vitro diagnostic devices during infectious disease outbreak. For COVID-19, we use this system as well for RT-PCR testing kit. This slide is about our PCR testing capacity for COVID-19. It is well known that Korea has conducted extensive lab testing and then found cases in early stages. We have expanded the testing capacity step by step. In the beginning of the outbreak, only KCDC was the testing lab available for lab testing. But later on, it expanded to the research institutes of public health environment. This is affiliated with local governments and private medical laboratories and hospitals gradually. Therefore, currently we have a total of 118 testing institutions available nationwide, and the capacity is 15,000 testing per day on average, and 20,000 testing per day maximum. I'd like to point out our contact tracing strategy as well. There are mainly 4 steps in our contact tracing. Actually, after we find out the confirmed case, we right away go for this rapid contact tracing. 4 steps are investigation, risk assessment, contact classification, and contact management. At the investigation step, we obtain preliminary information through interviewing the patient, primary physician, and family to compensate missing information or confirm the interview outcomes. We collect additional information at the stage of risk assessment. Information such as medical records, mobile phone location using GPS, card transaction log, and video footage are collected and investigated in this stage. Based on this information, we classify the close and casual contacts and provide guidelines from movement restriction to symptom monitoring. Next one is about also the one that we established after MERS outbreak in 2015, which we call this a smart quarantine information system. Actually, at this point, quarantine means the border control, border screening. In order to enhance our quarantine system at the point of entry after the MERS outbreak in 2015, we introduced the smart quarantine information system. This flow chart shows how the smart quarantine information system works. Information about the inbound travelers from the Ministry of Justice, Ministry of Foreign Affairs, airline companies, and major telecommunications companies are collected by KCDC's quarantine information system at the airports or airports. Then the information gets recategorized. This information about travelers from a country or region with infectious disease outbreak, their travel history is accessible by frontline healthcare providers during the incubation period. The next one is about the self-health check mobile app. Actually, we further adopted information technology for efficient and creative measures such as this kind of self-health check mobile app, as well as further we also developed the self-quarantine safety and protection app. The self-quarantine and special safety and protection app is used for those who are in self-quarantine after they entered Korea. And also, yeah. Okay. The last slide is about our social distancing campaign, and then this is the last strategy I'd like to emphasize. After the peak of the transmission on February 29th, we have recommended the public to practice social distancing. We advise the public to cancel non-essential travel, event, and social gatherings and stay home as much as possible. High-risk facilities such as religious, indoor fitness, and nightlife venues are strongly recommended to suspend the operation. Venues that remain in operation must strictly comply with the infection prevention guidelines. We will need to learn more about COVID-19. Till now, we have known that COVID-19 is highly infectious from its early stage and spreads rapidly with cold-like symptoms. New technology is required to enhance our traditional control and response measures, as well as to develop novel measures. I hope our experience can help other countries take effective measures against COVID-19. That's the end of my presentation. Thank you.
Thank you very much, Dr. Lee. We appreciate you taking time. It's already at night where you are, to give us your experience. Now we are moving into questions and answers. And colleagues, kindly enter your questions or comments in the chat box, and we will take them as they come. We see requests for slides and the recording. As usual, we will be sending these slides to you after the session. Kindly also register as a member. It makes it easier for us to be able to include you in that list and send you the slides as well. I'll take, hopefully this is the first question. I haven't left another one. This is from Prof. Taher Pillay from the University of Pretoria, NHLS, South Africa. And he or she says she has not talked about antibody testing yet. Prof. Taher is interested about antibody testing. Any experiences from you, Dr. Lee?
Actually, currently, the Korea is using only the RT-PCR lab testing method for the case confirmation. I know there are a lot of the inquiries and needs for this antibody testing for rapid testing because some countries do not have the lab facilities and so on. But actually, as I mentioned before, we need some kind of approvals usually for these testing kits, but we are just can use only this PCR testing method and testing kits for this emergency use authorization process. Only these testing kits are authorized by this the EUA system. But I know there are several the antibody testing kits developed by the Korean private companies. But what we are really concerning about is that the sensitivity and accuracy of these this antibody testing, rapid testing kits are not that high as this PCR lab testing. So there we have a certain doubts on that. That's why the Korean government do not use this antibody testing kit for the former the confirmation. So that's our situation. But I think for other countries, the situation will be different. So in order to adopt this testing method, I think you have to really know about its real accuracy and sensitivity of the testing kits that you are going to use, and then you have to know about all these details to adopt these testing kits. That's our comment on that.
Thank you, Dr. Lee. And this is a very important and recurring theme in all our sessions, antibody testing. And indeed, hopefully in the future, we will dedicate one of the sessions really on this. I'll take the next question from Augustine Onyegala. And he says to all of us, massive testing supported by massive laboratory networks across South Korea was very fundamental. How does Africa leverage on this? This is from Augustine.
Could you repeat the question again?
Massive testing supported by massive laboratory networks across South Africa was very fundamental. How can Africa leverage on this? I think he wants to learn from your lessons.
Yes, I also understand the African the situation as well. Yeah, that's the one related to the one the answer that I have already said before. We've done this one by this massive testing by the PCR testings, but for the African the countries, I think the labs should be set before for these testings, but most of the countries may not have these kinds of lab networks and the lab systems. In that case, I think we should think about the alternatives. As you mentioned before, it's like rapid kits and then the antibody testing and things like that. But I think that's why the Korea or other countries really should think about how to improve this the sensitivity and then accuracy of these rapid testing kits. But yeah, in Korea, actually, if there are we don't want to do that, but if there are more cases, the massive cases that cannot afford our with our capacity, maybe we will just consider the alternative testing methods as well. So for African countries, I think if your circumstance is not suitable for this the massive testing and things like that, I think you have to also think about the alternative method. That's the comments that I can say for now.
Thank you. I think the next question is also similar to what you are talking about in terms of so many tests done. I mean, how did you ensure availability of so many PCR tests?
Mm. I showed actually my presentation will be just distributed to the participants later. I actually explained about our national laboratory system. Actually, we have done this not for long. We just established this system just within just 4 years. We started from 2016. Actually, this kind of the infectious diseases, it's the new ones, and then this we actually classify this COVID-19, MERS, Ebola, such diseases as a class 1 diseases. The diseases that we have to really respond just right away, rapidly. That's the class 1 disease. For this kind of diseases, we really need some kind of strong national laboratory system. We really learned this lesson from our MERS outbreak. So we just established these kinds of lab network, not only the public ones, but including the private ones as well, even at the hospital level and also the commercial facilities as well. So, and this was the original, the basic network that we had. And also, the Korean government just quickly developed the test and disclosed it. In the middle of January, actually, we did it, and then we tested our first confirmed cases. After that, we right away just disclosed all these testing methods, and then about the virus, the DNA sequencing, and so on. So we just disclosed our testing. We developed it, and then we disclosed this testing method, and then also the private labs and private companies could just develop their own things, and then through our EUA system, we approved and authorized all these testing kits for only for 5 companies right now. And then we expanded all these testing methods to the private sectors as well. And then this was very smoothly done because we've already had this kind of laboratory network before. And then we've got all these experts help, and then they were also in part of training these expert groups in academic society. They participated in the testing and so on, training and so on. And then currently we are working with them for quality assurance and then all kinds of management as well. So this was all done in this network setting.
Thank you very much, Dr. Lee. Although this is not usually our practice, there is Mustafa Bello. His hand has been up, I think, well before many of the questions came through. So I'll allow Mustafa to unmute and pose the question. Go ahead, Mustafa.
Hello, can you hear me?
Yes, please go ahead.
So thank you very much for the exception and opportunity. I didn't want my question to be missed, so that was why I had to raise my hand. So the NCD here in Nigeria has requested CDC to sort of do a catalog some of these key lessons learned from countries like South Korea that have done very well in the control of the COVID-19. Specifically, they want us to be able to share with them the key challenges that South Korea will have learned through this process, and where we can learn and adapt to our own context. So I wanted to ask the gentle lady if there are specific challenges and lessons learned from all of this that South Korea has been able to their own experience, and what they can specifically share in terms of the challenges and lessons learned.
That's very good question. I think even now we are also facing the challenges as well. The the largest challenge, biggest challenge is that actually we still do not know much about this virus. We have known a lot about this, but we still needed to know. Like currently, we are just talking about asymptomatic infection, the patients, and then also sometimes we also have some reports about reconfirmation of the discharged patients, and then we are just much more concerning about the characteristics of this virus, their incubation period, and then their viral shedding period, and then all these things we still needed to investigate and study. Actually, yes, my lab division, they are really studying really hard on this virus, and then we really want to share our knowledge if it is we just reach to some conclusion, but we are still under the investigation. And then I think some other countries like European countries and some other countries with big outbreaks, they are having the same challenges as well. The challenge is that another challenge that I'd like to emphasize is that you cannot estimate the pattern or the of this outbreak. Actually, we've had the first phase with some imported cases from China. It was in January, and then the cases related to this informed cases, imported cases. And then in early February, we were really worried about whether we are just missing some cases, and then they might transmit to others, and then it will just cause the local transmission and so on. And then actually we have met this second phase, but it was really big, huge cluster, as I mentioned, and then some of the clusters. So we had this big outbreak during our phase 2. Fortunately, we could control this big, the increase of the cases and this cluster. Now we are experiencing again the importation of the cases from the Europe and then America and Asia, and not only from China, it's all around the world. It became the global pandemic. So it's now another challenge that we are just facing. And also, we still have some local infections, some clusters and sporadic clusters and things like that. And then another thing is that, yeah, something like that. And so we are, again, worrying about another community transmission or community spread would occur. So we do not want to face the fourth phase, we may say, with another wave of the community transmission. But it is really hard to anticipate what would come next after we just go over a certain state, a certain phase. The current, our concern, I would say the last one is about these the high risk group control. It's especially for the hospital infections, and then some infections, the clusters in the long-term care facilities, and then some clusters in the maybe some related to high risk groups and so on, because these cases would lead to the severe cases, and then that is the most the important and then the point that we are just concerning about. So all these are the challenges. Till now, actually, we didn't have any kind of model or any kind of specific system. We always thought about the all kinds of scenarios, And then we actually planned all the measures for the worst scenario. That was our response strategy that we've taken till now. Thank you.
Thank you very much, Dr. Lee. A lot of questions coming through indeed. I'll try to also randomly pick as we move on. Mustafa, you can lower your hand. I guess I think your response has already been taken. Thank you. The next question is okay, I'll pick from Obed. He says, "Is sensitivity only about kids? What about sample collection? Do you have? What about sample collection? I think there is some typo there. Do these samples contribute to low sensitivity?" And I'll tie this with another question that came talking about recent article, which I think came from South Korea. I'm trying to find who that is, but he was mentioning that sputum was also selected. Can you comment on sample types, Dr. Lee?
If I understand correctly, sorry.
Zakayo, kindly mute if you are not speaking. Go ahead.
Okay. So you want to know about the kind of procedure of a sample collection and so on, I think, and then how the test is performed, right? Actually, the specimens are collected by doctors, nurses, or clinical laboratory scientists at the designated locations. For example, we have several screening centers and stations. Maybe you've heard of drive-through screening centers or walk-through screening centers. All those are located in the communities. We take these specimens from the screening centers, either there or from some the clinics, surgery clinics, and then the doctors and nurses do that, and then also the clinical laboratory scientists do that. We take the specimen from the upper respiratory tract. Actually, this is required. The lower respiratory tract specimen are also collected. It's kind of optional. If this patient has a sputum. Generic testing may be performed directly at the screening centers if the center is equipped with such capacity like a PCR and so on, or the specimen can may be sent to a testing center. These drive-through screening centers or walk-through screening centers do not usually have these lab capacity. So they only take the samples over there, and then they send these samples to the testing center. So all these the testings are done at the lab.
Thank you, Dr. Lee. The next question says, did any prior experience with other outbreaks like MERS help you in your response to SARS-CoV-2? Did any prior experience with other outbreaks that you had, for example, the MERS, contribute?
Yeah. Actually, what we are doing now is all from the MERS outbreak, these lessons. We've built this kind of this EOC, and then KCDC's capacity building. All these things were done from the MERS outbreak, as I mentioned at the presentation. We've learned that we really needed to be prepared. Actually, for last several years, the world was talking about the public health emergency preparedness and response. And then last year, we were talking about this pandemic influenza preparedness, because last year was like a 10-year after this 2009 pandemic influenza preparedness. Actually, we've done a lot of exercises and training last year for this pandemic influenza. And then these kind of trainings and also exercise really helped us to have the response to take some real actual measures to this COVID-19 as well. Actually, from our lab division, I think last year in December, they had this special tabletop exercise. I don't know, but coincidentally, their subject was disease X. These X were caused by the novel coronavirus at the time. So last December, our lab division, all the officers were they considering about how to detect this novel coronavirus, and then how we can do that. That was kind of exercise at the time. And on December 31, actually, we've got reported from the Wuhan about this the pneumonia with the unknown the cause. And then when we just heard about this one, and our lab just started to working on to detect this unknown coronavirus. So we developed, first of all, the pan-corona virus testing kit by KCDC. And after like a 10 days later, China, actually, they just shared this the COVID-19 virus DNA sequencing to WHO. When we just shared, when we received this kind of sequencing materials, then we just adjusted our pan-corona virus testing method to specifically this to this COVID-19. So we developed this kind of testing methodology from our experience, and from our training, and from our the consideration. And then when we just first tested with this first confirmed case, we had more development with that the samples, and then we could expand our testing kits to other testing facilities and the companies as well. So the training and exercise and the preparedness are the key the elements that we really had taken before this COVID-19, and then we learned all these lessons from MERS outbreak, because we were not prepared at the time, for sure.
Thank you. Indeed, great lesson learned. I think hopefully we will be prepared in the next outbreak as well. I'll also take another question from Muhammad Jamil, and he says, have you seen any cases of reinfection? Have you seen any cases?
Sorry, I just missed the question, sorry.
Yes.
Reinfection.
Reinfection, yeah.
Yeah, that's the one that we are really concerned about as well. We are still under investigation. We are not sure about this is reactivation, or this is maybe reinfection, but we now say it's just a reconfirmation. Because we haven't done any investigation, we haven't completed the investigation yet, because we are not sure whether this would be, excuse me, reactivation or reinfection, because this viral shedding is quite unique about this COVID-19, we think. So we still are doing the testing and investigating for various kinds of possibilities. So if we have this investigation, excuse me, investigation, I will share with you the result that we get. Actually, each case will be reviewed and compared to one another for differences to see if the general information of a virus is different. Because if they are different, then we may say it's reinfection. But they are not. If they are the similar or same, I think they might be the reactivation. So we need to look at each case very seriously and thoroughly.
Yeah. Thank you. Totally, I think we still continue to learn. I would like to agree with Lila. He or she says relevant questions indeed. Indeed, if there's no time to respond, hopefully we ask Dr. Lee to send answers by email. We'll follow up with Dr. Lee. Another question from Brennan says, in the US, we do not have enough PCR tests for all suspected cases. In South Korea, were you able to test all suspected cases who called, even if the symptoms were not severe? In Africa, there likely will not be enough tests to test all suspected cases. Any recommendation on how to ensure countries are testing smartly?
That's a very, very good question, but very difficult to answer. Yeah, we actually also considered that kind of the problems, because if we have these huge cases, the outbreak or cluster coming, maybe we have to prioritize the testing subjects. From the public health point of view, maybe it might be also my personal opinion, but from the public health point of view, we think that you have to prioritize by the risks. As you said, for example, as you mentioned, as you mentioned, this is about the high risk groups. Should be on the priority. Maybe a high risk groups with the severe symptoms, they should go for the top priority. And then some the cases, some suspect cases that might have a high risk or possibility for further transmission. Maybe it's like the epidemic link is very, very high. Maybe he might have a huge contacts, things like that. He will be, or certain groups should be tested very, very fast, because you should really, really stop the cluster. That's the key to control the bigger spread of these cases. So there might be very depending on. So that's why at the field, we really ask our EIS officers for the risk assessment at the field, because all the circumstances will be different at the different fields. So the EIS officers or some public officers or any officers who are in charge in the field should evaluate the risks and then should categorize or prioritize for the testing subjects.
Thank you very much. Interesting insights indeed. As we move on, I just want to pause a bit and look out for our colleagues from WHO Africa CDC. We are getting interesting insights in here. Any remarks, Fausta, Lara?
Any insights, General?
Yes, Dr. Lee, I was just looking out for colleagues from WHO. Yes, Fausta.
Thanks.
Yeah.
Thank you, Anafi, and thank you, Dr. Lee. It's very interesting, and I can say at this point, I'm really focusing on learning the Korean experience, and especially different alternative techniques that they use in testing. And I think one of the things that I'm also learning is preparedness. And as you have said, I think we also, from the experience, we might also, it will also help us to see how we can expand our testing capacities, and also how this can help us in arresting further spread as we are moving with the COVID-19. Thank you very much for this opportunity.
Thank you, Foster. Another question, in addition to diagnostics, from, I think this is Gabriela Toria, says, we have a chest scanner. Has a chest scanner been used as an additional tool for diagnosis? It was reported that PCR tests are not very sensitive. What is your experience?
Actually, at first, because at the early stage, maybe in January, actually our government also prepared for these kinds of test scanner, the equipment to distribute to the local public health centers. Because when China reported these cases, it was all mostly related to pneumonia. But later on, we found out the fact that actually there are so many the people with light symptoms. Sometimes just a little no symptoms they just feel. So for Korea, actually, we just expanded our case definition to include all those kinds of people. So later on, actually, we didn't use chest scanner, but like from the previous questions, if you have a limited resources, and then if you need to don't have a certain lab testing capacity, actually. In China, they also used this kind of critical symptom case instead of the lab confirmed cases. I think they just reported 10,000 more cases at once with just the clinical symptoms. In that case, you may also use this chest scanner as the alternative for the testing. But as I mentioned, in Korea, we only use the PCR testing, and then we think those who do not have these symptoms or little symptoms, they are also very big. They have a high transmissibility of this virus as well. So the chest scanner would not be the right method if you use that as the only possibility. But alternatively, it may be useful. But for now, I think we all see the symptoms. If we just consider all the symptoms, I think yeah. Currently, we do not use the chest scanner as alternative or complementary one for now. But at the beginning, we also considered that. But when we found out there's some more characteristics about this disease, then we actually do not use this just essentially, but like for the additional additional the examination, actually at the hospital they use this one. Yeah.
Yeah, indeed. And really, we are now at the top of the hour. So I would take the last questions. These are from Maynard, before we close. And he says, does COVID-19 prefer different climatic environments? And does it change its virulence season to season? That is summer, spring, or winter. And he goes on to say, does COVID-19 exposure create immunity? If so, for how long?
That might be very difficult to just anticipate, but I can say that we still need to learn about that. Yeah, but yeah, we hope we will finish soon. But when we see about these global pandemic, I think yeah, this would go like pretty long. Like it might not be very the big outbreak or so, but we still need to just deal with this virus for a long time. And then I can see some, because because if it's only in the certain areas or certain reasons, maybe we will be much more easier to say some certain the anticipation, but it's all the global pandemic. So as I mentioned that even though we just minimize our local infection, but we again have some imported cases. And then if we go over and over this kind of cycle, I think we will, have to continue to respond to this COVID-19 maybe for some more time.
Thank you very much. Really, a lot of questions indeed, some of them difficult ones. But the truth of the matter is we are all learning, and this is why we asked colleagues from the Korea CDC to come and share with us experience. Indeed, will teach us. They had a bit of experience from the mess and they applied it. So hopefully, I think we continue to learn more and more. Dr. Lee would kindly ask that we will follow up with a lot of questions that are in the chat box, and then we can send them back to the presenters. As we close, I just want to let you know that we continue to line up interesting sessions coming up. Hopefully, we will also be calling upon our diagnostic. There were a lot of questions around diagnostics, what they do. So we are hoping that we want to hear that from the horse's mouths. So hopefully we will engage our diagnostic partners to come forward and also give us from their perspectives what they are offering, and possibly answer some of the questions that were in the chat box. In a nutshell, in 30 seconds, your final remarks, Dr. Lee.
Thank you very much for inviting me and then giving me some opportunity to share our experiences. And I also want to listen to your experiences if you are facing some difficulties or certain important matters, because we really need to share the knowledge and experience to overcome this global crisis, global pandemic. We still don't know much about this virus, so we really need to share the knowledge. So let's keep in the line, and then the Korea CDC is always willing to keep in line with the African friends. Thank you.
Thank you. Yeah, and remember our journal, the African Journal of Laboratory Medicine, is soliciting for your high impact articles on outbreaks. Please visit the journal website and please share as much as possible. Until we meet again, I would like to say goodbye.